Glomerulonephritis is a clinical syndrome caused by injury to and inflammation of the glomerulus. It's characterized by a constellation of findings, including hematuria and dysmorphic red blood cells in the urine, in addition to variable degrees of proteinuria. Patients often present with acute kidney injury, hypertension, and edema. What caused the initial injury to the glomerulus? It turns out a whole range of autoimmune diseases and infections are implicated. In this video, we'll cover the clinical presentation, diagnosis, and management of glomerulonephritis. In this scene, that injured and leaky glomerular basement membrane is symbolized by the Great Wall of China during the raids of Genghis Khan. Granted, the wall at that time was more of a collection of defensive fortifications constructed by multiple dynasties, predating the Great Wall of China we think of today. At Sketchy, we always symbolize glomerulonephritis as a red knot, kind of like the ones at the end of the Mongol flag up there. Think of them as glomerular tufts. As the scene progresses, we're going to see some serious leakage across that basement membrane. See that fire there? Glomerulonephritis is caused by a direct insult to the glomerulus, such as immune complex deposition, or is part of a larger systemic vasculitis. Regardless of the etiology, the end result is inflammation of the glomerulus, which damages that fragile filtration barrier. This results in glomerular bleeding, as evidenced by the blood leaking across the Great Wall, as well as variable amounts of proteinuria, embodied by that dude down there escaping with his meat cart before the next raid begins. Renal impairment is common. More rapidly progressive forms of glomerulonephritis can cause AKI, which we always symbolize with a cracked kidney. Alternatively, a chronic glomerulonephritis can cause a progressive decline in GFR, a hallmark of chronic kidney disease. So we've also included a couple of chronically shriveled rock-like kidneys. We'll get to the clinical manifestations in a bit. But first, the causes. So many potential causes. Glomerulonephritis is associated with primary glomerular disorders or systemic disorders that also affect the glomeruli. We'll start off our discussion with IgA nephropathy, the most common cause of glomerulonephritis in adults. Notice that those training dummies kind of look like IgA molecules. Next, we'll cover a few systemic diseases that affect the glomerulus, including post-streptococcal glomerulonephritis, the most common cause of glomerulonephritis in children, though it can be seen in adults too. This glomerular disease follows a pharyngitis or skin infection caused by strep pyogenes, so we've brought in our recurring pyogenes pie. Next up, membranoproliferative glomerulonephritis, abbreviated MPGN. This Mongol here is holding a flag along the wall to represent the membrano part of membranoproliferative, a thickened glomerular basement membrane, that is, and for the proliferative part, we've drawn in his army proliferating behind him. One class of disease that causes this pattern of injury is immune complex-mediated MPGN. Immune complexes deposit in the setting of chronic infections, autoimmune diseases, or monoclonal gammopathies like multiple myeloma. So his army wields antibody maces, evoking an image of immune complex deposition. Another less common type of MPGN is termed complement-mediated MPGN. In this form of glomerulonephritis, dysregulation and abnormal activation of the complement system results in deposition of complement products in the glomerulus. At Sketchy, overactive complement is represented by excessive, complements. Hence the complimentary high five being thrown by these two Mongol comrades. Dude, you were so good during that raid. Nah, brah, you were. Oh, shut up, you were dog. No, you shut up. That's probably how it went. Next up, systemic lupus erythematosus. Lupus is associated with both nephritic and nephrotic syndrome. So we've brought back our recurring lupus wolf patrolling the wall. Lupus nephritis comes in 6 classes based on histological and clinical features, with class 4 being the most common and most severe form. Hematuria, nephrotic range proteinuria, hypertension, and reduced GFR are all likely to occur in patients with class 4 disease. Yeah, it's a bad one. Antiglomerular basement membrane antibody disease, also called Goodpasture's disease, is a rare cause of glomerulonephritis and pulmonary hemorrhage in both children and adults. This disease involves antibodies that are directed against an antigen intrinsic to the glomerular basement membrane. So we've lined up these antibody arrows along the wall, which represents the GBM. Granulomatosis with polyangiitis, or GPA, previously referred to as Wegener's granulomatosis, is a multisystem vasculitis characterized by destruction of the upper respiratory tract, as well as nodules or cavities in the lower respiratory tract. Our recurring symbol is the Wegener sand wedge, this time being used to knock a smoke bomb onto a few unsuspecting guards. Microscopic polyangiitis, abbreviated MPA, is a related systemic vasculitis syndrome that shares many of the clinical manifestations of GPA. So we've drawn in a colony of microscopic polyangiitis fire ants. We'll get into a few distinguishing features later on in the sketch. Eosinophilic granulomatosis with polyangiitis, or EGPA, previously referred to as Churg-Strauss syndrome, is another multisystem vasculitis associated with glomerulonephritis. EGPA is characterized by allergic rhinitis and asthma, followed by eosinophilia, and final progression to vasculitis. Notice the inhaler smoke bomb, which highlights the asthma symptoms that are associated with the disease. Not to mention that churg of a sneeze caused by allergic rhinitis. Really puts the churg in Churg-Strauss, you know what I mean? Lastly, rapidly progressive glomerulonephritis, or RPGN, is a clinical syndrome in which rapid deterioration of renal function occurs over weeks to months, culminating in end-stage renal disease. RPGN is associated with crescent formation and necrosis on histology. Hence the deadly crescent weapon, along with that black, necrotic-looking armor. Not only that, he's jabbing that kidney shield to emphasize the rapid decline in renal function that occurs. This severe form of glomerulonephritis can occur with any of the aforementioned immune complex-mediated glomerulonephritis syndromes, though is especially likely in cases of anti-GBM antibody disease, as well as the ANCA-associated vasculitides GPA, MPA, and EGPA. Alright, let's see how our patient is doing, because there are some key symptoms that can point you towards the diagnosis. While glomerulonephritis usually presents with microscopic hematuria, some patients may present with dark or cola-colored urine, which is a sign of gross hematuria. So, trickling out of young Genghis Khan's bath is some cola-colored water. Gotta get washed before the next raid, baby Genghis. Push my squeaky queen with a Mongol. I don't know, that's probably how it went. Patients can also present with lower extremity swelling due to decreased GFR and retention of sodium and water by the kidneys. Eye swelling due to facial edema is common as well. Because of fluid retention, weight gain is also common. Alright, let's get into a few more specific historical clues. First, ask about a recent upper respiratory infection. About half of patients with IgA nephropathy present with one or multiple episodes of gross hematuria along with a URI within the last 5 days, such as a bacterial tonsillitis or viral URI. This is dubbed a synpharyngitic hematuria because the hematuria and URI occur together. So we've added some trickling blood to this sick soldier next to the IgA training area. Post-strep glomerulonephritis, on the other hand, presents after an infection with certain nephritogenic strains of group A strep. So over at the strep pyogenes pie shop, we've shown 2 of these infections. Strep pharyngitis, aka strep throat, which is symbolized by that red throat bandana, and, secondly, a strep skin infection, symbolized by that crusty rash of pie filling on his face. Glomerulonephritis typically follows 1 to 3 weeks after strep throat and 3 to 6 weeks following a strep skin infection. So we have the head pastry chef of the Mongol army marking his monthly calendar, indicating that Pyogenes pies need to be ordered weeks in advance. Sorry, kid. Remember, this is different than the so-called synpharyngitic hematuria that characterizes IgA nephropathy, in which hematuria follows the URI only after a couple days. Let the infections continue. When you think of immune complex MPGN, think of a chronic antigenemia or chronic circulating immune complexes that occur with chronic infections, autoimmune disease, or monoclonal gammopathies. Hepatitis B and C viral infections are the most common cause of immune complex-mediated MPGN. Hence the hepatitis hippo helmet on the horse with the long membranous flag. Hep C-induced MPGN, specifically, is commonly associated with mixed cryoglobulinemia. So we've also given the hippo horse warrior a cloak of cryoglobulins, which are usually composed of IgMs stuck to IgGs just floating around and mucking up small vasculature. Other systemic vasculitis symptoms are also seen with mixed cryoglobulinemia, including palpable purpura, arthralgias, and fever. Chronic bacterial, fungal, and particularly in the developing world, parasitic infections can cause immune complex mediated MPGN. Again, this is thought to be the result of immune complex deposition in the setting of chronic antigenemia. You know what? Let's add autoimmune disorders and monoclonal gammopathies to the list while we're at it. Immune complex mediated MPGN is associated with lupus, for example, and more rarely with Sjogren's syndrome and rheumatoid arthritis. MPGN can also occur in patients with monoclonal gammopathies secondary to multiple myeloma, lymphoma, and MGUS. Just too many antibodies. So they deposit as immune complexes in the glomerulus. Lupus is not only associated with MPGN. As we mentioned earlier, lupus nephritis can present with a range of renal biopsy findings. 6 classes, in fact. Keep an eye out for other features of lupus, such as malar rash, arthralgias, or pleuritis, discussed in detail over in our Lupus Teen Wolf sketch. Granulomatosis with polyangiitis is associated with other systemic symptoms as well. You know, it being a multisystem vasculitis and all. A few distinguishing features include ENT and pulmonary manifestations. ENT symptoms are much more common in GPA and include sinusitis and persistent rhinorrhea, as well as otitis media and otorrhea. Oronasal ulcers and hearing loss are also common. Pulmonary symptoms of GPA and MPA include dyspnea, cough, pleuritic chest pain, and hemoptysis. Patients with eGPA will typically have a history of allergic rhinitis and asthma, symbolized by that asthma inhaler smoke bomb, if you recall. The pink spots on his chest represent the peripheral and organ eosinophilia that follows. The most commonly affected organ is the lung, manifesting as an eosinophilic interstitial lung disease with pulmonary opacities, pleural effusion, nodules, and alveolar hemorrhage. And don't forget about anti-GBM antibody disease, symbolized by those antibody arrows lining the Great Wall. Anti-GBM antibody disease is a systemic vasculitis disease caused by autoantibodies directed against type 4 collagen in the glomerular basement membrane. Hence the whole glomerulonephritis thing. However, it turns out that they also target alveolar basement membranes, which results in pulmonary hemorrhage. For all the small vessel vasculitides we just talked about, we're talking mixed cryoglobulinemia, GPA, MPA, eGPA, anti-GBM. Expect all the typical systemic vasculitis symptoms as well, including fever, arthralgias, and fatigue. The typical skin manifestations of small vessel vasculitis include a non-blanching palpable purpura. Hence the palpable purple rubble on this resting soldier. Yep, just taking a nap. I'll be fine. Patients with nephritic syndrome usually present with hypertension secondary to volume overload from renal insufficiency. So we've added some high pressure steam to our injured kidney warrior. Look for signs of volume overload on physical exam. I mean, just take a look at baby Genghis's edematous pants, face, and body, representing lower extremity, periorbital edema, and in patients with long-standing edema, anasarca, which appears as widespread swelling of the skin due to effusion of fluid into the extracellular space. Chronic anasarca can give the skin a tough, woody appearance. Elevations in BUN and creatinine may occur with acute or chronic glomerulonephritis. AKI, for example, can occur with acute pathologies, especially that rapidly progressive glomerulonephritis we mentioned earlier, represented by that necrotic armor and deadly sickle weapon. Chronic glomerulonephritis, on the other hand, is associated with a progressive decline in GFR, a hallmark of chronic kidney disease. This dude running off with all his worldly protein possessions represents proteinuria. In the setting of glomerulonephritis, urinalysis can show variable degrees of proteinuria, typically greater than 150 milligrams per day. These values can sometimes be in the nephrotic range even. We are not done with that urinalysis, friends. Let's look at that sediment. With glomerular bleeding, you'll likely see more than just red blood cells in there. The hallmark finding consists of dysmorphic red blood cells, plus or minus red blood cell casts. So we've added an unsettlingly dysmorphic red soldier here, as well as some stacked red helmet casts. And since we're looking at their urine, remember that gross hematuria may also be present in some cases, especially post-strep glomerulonephritis and IgA nephropathy. Brown or Coca-Cola urine is the classic description. Time to get some more labs. Patients should have C3 and C4 complement levels checked. Both may be low in cases of glomerulonephritis that involve immune complex formation. Hence the broken C3 and C4 sign up there. Notice that we've placed the sign next to SLE and immune complex mediated MPGN. These conditions are associated with immune complex deposition and overactivation of complement. In post-strep glomerulonephritis, C3 levels are significantly depressed during the first couple weeks of the disease process. C3 levels then return to normal 4 to 8 weeks later. C4 levels are usually normal. Interestingly, both C3 and C4 are usually normal in IgA nephropathy, which is why we've placed the warrior practicing on the IgA dummies far away from the broken complement sign. We also placed a broken C3 chunk of sign next to those two Mongol warriors throwing up a complimentary high five in front of the proliferating army. Our symbol for complement-mediated membranoproliferative glomerulonephritis. In this form of MPGN, IgG antibodies are directed against C3 convertase, which leads to overactivation of the alternative complement pathway. That means low C3 and typically normal C4. Order anti-nuclear antibody and anti-double-stranded DNA antibody levels as well, which can be positive in autoimmune diseases such as lupus nephritis. Down, boy! If you suspect post-strep, check anti-group A strep antibody titers, represented by these antibody forks directed against these delicious pieces of Pyogenes pie. Don't mind if I do. Word of caution if just the ASO titer is used. It might be positive after strep pharyngitis, but falsely low after a recent strep skin infection. A streptozyme test covers 5 different strep antibodies. Next, a reminder to get serology for HBV and HCV. Additionally, patients with a known history of hepatitis C or clinical features of cryoglobulinemia should also be tested for cryoglobulins. Test for serum-free light chains, and order a serum and urine protein electrophoresis with immunofixation to screen for monoclonal gammopathies such as multiple myeloma, Waldenstrom macroglobulinemia, and MGUS. Remember that these conditions are associated with myeloproliferative glomerulonephritis. Test for anti-GBM antibodies as well, which would be positive in anti-GBM antibody disease. Lastly, you may also test for anti-neutrophil cytoplasmic antibodies, ANCA, which can be positive in systemic vasculitides such as GPA, MPA, and eGPA, all the PAs we discussed earlier. At Sketchy, our recurring symbol for antibodies against the neutrophil is an antibody arrow directed against white cell-themed EMTs, because neutrophils are like the first responders of the immune system. Neutro first responders, if you will. Many patients with glomerulonephritis should undergo a renal biopsy to obtain a definitive diagnosis. This guides management decisions. In suspected self-limited disease, such as that seen with post-strep glomerulonephritis and IgA nephropathy, it's less common to get a biopsy unless the presentation is severe or if the diagnosis is uncertain. Let's take a look under the microscope, shall we? In post-strep glomerulonephritis, immunofluorescence microscopy reveals a diffuse granular pattern within the mesangium and glomerular capillary walls due to deposits of C3 and IgG. So we added a granular, glowing green pie out in the mesangial field. The mesangium, remember, is the support tissue of the glomerulus that surrounds the capillaries. IgA nephropathy appears as mesangial IgA deposits on immunofluorescence microscopy. So, out on this mesangial battlefield, we've added a fluorescent glow to those IgA training dummies. These IgAs are often deposited with other immunoglobulins, such as IgG and IgM, as well as C3. How about that membranoproliferative one? Well, on light microscopy, the glomerular basement membrane is thickened. It's got that whole membrano thing going on. Not only that, as the mesangium proliferates into the basement membrane, it splits it apart, forming that characteristic tram track double contour appearance. Just think of this flag following the contour of the wall. On immunofluorescence microscopy, immune complex-mediated MPGN is characterized by granular deposition of immune complexes and complement components within the mesangium and capillary walls. Just look at the fluorescent green glow of their immune complex weapons. Intimidating. Complement-mediated MPGN, on the other hand, is characterized by, you guessed it, deposition of complement components, especially C3. So expect bright staining for C3 within the mesangium and along capillary walls. There's also a special subtype of complement-mediated MPGN with a special electron microscopy finding. It's characterized by linear deposits of electron dense material in the glomerular basement membrane. It's called, wait for it, dense deposit disease. We'll highlight the linear dense deposits in the GBM with this dark linear fuse connecting these dense bombs on the Great Wall. Anti GBM antibody disease appears as linear deposition of IgG along the glomerular capillaries on immunofluorescence microscopy. Classic finding right there, my friends. And how about those ANCA ones? You know, GPA, eGPA, and AARP, or whatever. On immunofluorescence, those ones show, get excited, absolutely nothing. Yep, they're called posse immune. Hence the shushing going on over there. Just keeping it quiet. Sneaky, sneaky. The histopathology of lupus nephritis is variable. It's easy to confuse with other immune complex mediated glomerulonephritis. However, it characteristically presents with the so called full house immunofluorescence pattern of glomerular deposits that stain dominantly for IgG and contain codeposits of IgA, IgM, C3, and C1q. That really bad, rapidly progressive glomerulonephritis we mentioned earlier is characterized by crescent formation within the glomerulus, seen on light microscopy. This finding is thought to represent a nonspecific response to severe injury to the glomerular capillary wall. Let's sum up everything we've learned so far with a sample assessment. Mr. Khan is a 27-year-old man who presents with 2 days of dark urine. He reports having a sore throat 2 weeks ago that was treated with antibiotics. He's also noted swelling around his eyes for the past few days. His blood pressure is 160/98. His physical exam is notable for periorbital edema. His labs are significant for a BUN of 36 and a creatinine of 1.8. Urinalysis shows protein 3+, RBCs 50 to 75 per HPF, and RBC casts. Overall, his picture is most consistent with glomerulonephritis. Once you've made the diagnosis of nephritic syndrome, it's time to start treatment. Management of post-strep glomerulonephritis is predominantly supportive and focused on treating the complications of the disease, particularly those due to volume overload. These include hypertension and, less commonly, pulmonary edema. General measures include sodium and water restriction and loop diuretics. Also, if the strep infection is still present, penicillin is given, symbolized by our recurring purple penicillin pencil. Most patients, especially children with post-strep glomerulonephritis, have an excellent prognosis, though some patients will develop hypertension, recurrent proteinuria, and renal insufficiency many years after the initial illness. Next, how about MPGN? So many causes. And what do you know? The treatment here is to treat the underlying cause. This is especially important to consider in cases of hepatitis, when adding immunosuppressive therapy can be detrimental. You need an immune system if you want to fight a hepatitis virus. For all the other causes of glomerulonephritis in the scene, the 3 primary treatment objectives are control of inflammation, control of blood pressure, and prevention of irreversible damage. Inflammation is controlled with glucocorticoids and other immunosuppressants such as cyclophosphamide. As you know by now, glucocorticoids are symbolized by that eerie moon face, reminiscent of the moon faces appearance that occurs with chronic glucocorticoid use. And in this scene, it's incorporated into a few well-placed glucocorticoid cannonballs over near IgA nephropathy, lupus nephritis, as well as anti-GBM and the posse immune vasculitides. ACEs and ARBs are used to control blood pressure and prevent irreversible damage to the glomerulus, highlighted by the ACE shield held by the corticosteroid catapulter. The treatment of choice for anti-GBM antibody disease and certain cases of RPGN is plasmapheresis combined with previously discussed anti-inflammatories. We've depicted plasmapheresis at the wall here, with this guy gathering the stray arrows, filtering the blood of immunoglobulins, if you will. Well, you know what they say, history is written by the winners. So let's recount today's events, shall we? Glomerulonephritis is characterized by glomerular bleeding and variable amounts of proteinuria. Renal impairment is common whether acute or chronic. Rapidly progressive glomerulonephritis is a clinical syndrome in which rapid deterioration of renal function occurs over weeks to months. It can occur with any of the immune complex-mediated glomerulonephritis, anti-GBM antibody disease, or ANCA-associated vasculitides. Renal insufficiency presents clinically with lower extremity swelling, facial edema, and weight gain. IgA nephropathy typically presents with hematuria within a few days of URI, while post-strep glomerulonephritis presents with hematuria 1 to 3 weeks after a strep throat infection or 3 to 6 weeks after a strep skin infection. Any chronic antigenemia, like a Hep B or C viral infection, a chronic bacterial infection, monoclonal gammopathy, or autoimmune disease, are associated with so-called immune complex-mediated membranoproliferative glomerulonephritis. Complement-mediated MPGN is caused by overactivation of the alternative complement pathway. Renal involvement is common in patients with lupus who can present with either nephritic syndrome or nephrotic syndrome. Anti-GBM antibody disease also causes pulmonary hemorrhage. The ANCA-associated vasculitides, GPA and MPA, are associated with ENT symptoms and pulmonary symptoms, while EGPA is characterized by allergic rhinitis, asthma, and eosinophilic interstitial lung disease. And don't forget the usual symptoms with these small vessel vasculitis syndromes, including fever, arthralgias, fatigue, and palpable purpura. Common objective findings include hypertension and edema. On labs, check BUN and creatinine for signs of kidney injury. And get a urinalysis, which may show variable degrees of proteinuria, hematuria, dysmorphic red blood cells, and red blood cell casts. Check complement levels. You'll see low C3 and C4 in lupus and immune complex-mediated MPGN. Check ANA and anti-double-stranded DNA antibodies too, which also point to lupus. Hep B and C viral serologies can be checked as well. And if mixed cryoglobulinemia is suspected, you can check for cryoglobulins too. You can also test for serum-free light chains and perform serum and urine protein electrophoresis to rule out a monoclonal gammopathy. Back to complement. Typically, only low C3 is seen in post-strep glomerulonephritis and complement-mediated MPGN. If you suspect post-strep glomerulonephritis, check anti-group A strep antibody titers. Test patients for anti-GBM antibodies. Lastly, test for ANCA, which can be positive in systemic vasculitides such as GPA, MPA, and EGPA. Many patients will need a renal biopsy to obtain a definitive diagnosis and guide management decisions. Management for post-strep glomerulonephritis is supportive and involves loop diuretics and salt and water restriction. For all those membranoproliferative causes, treat the underlying cause. And for the rest of them, glucocorticoids, immunosuppressive agents, and an ACE inhibitor to control blood pressure and prevent further glomerular damage. Oh man, that sketch was good, wasn't it?
Yo, bro, that sketch was killer sweet.
Thanks, man. You were good too.
Nah, bro, you were way better than me. Don't you dare say you weren't.
Nah, dog. You were the good.